Welcome everyone. It's great to see, am I on? It's great to see such a wonderful house for the Invitational lectures in the Humanities. I've just been warned by a very reliable source that there may be a few numbers in this lecture. So if anybody would like to leave armed with that warning, didn't expect that to have any kind of effect. Welcome to the Cogut Center's Invitational Lecture in the Humanities. I'm Michael Steinberg, I'm the director of the Cogut Center. This is our annual event in which a prominent member of the Brown community, faculty, considers pressing issues in the humanities, issues of importance to scholarship and to the world at large. The occasion gives us, the university and the community, the opportunity to learn from our most distinguished colleagues, many of whom have more regular opportunities to speak off campus than at Brown. Previous invitational lecturers have included President Simmons, Professors Charles Larmore, Tricia Rose, and Eric N. Naturally, it's a particular pleasure to welcome Christina Paxson today, not only as our new president, but also as a scholar with career-long concerns that are of particular and fundamental importance to the humanities. Perhaps more at Brown than anywhere else, the humanities represent both areas of the university as well as a dimension of the university as a whole. On the one hand, the humanities refer to disciplines and departments of varying ages and histories, as well as to a variety of interdisciplinary initiatives and centers in teaching and research and public service. More generally, the humanities refer to the shared institutional and intellectual responsibility to human conditions, their understanding, and their improvement. In an age of globalization, the university serves at once as an agent of global contact as well as a place of its critique. Here, the humanities are key to the understanding of worldly knowledge and practices. Humanistic practices focus on the local as well as the global, not in terms of oneness, universality, or indeed flatness, but rather in terms of the infinite multiplications of difference. We go for variability and individuality rather than for aggregations. The humanities affirm the importance of translation across cultures, between people, between languages, across genres. At the same time, however, and here is where we do make life difficult for our interlocutors, starting probably with our parents, we insist on the empirical and existential realities of untranslatability. We want to communicate, but we also want to hold on to those sentiments, experiences, and utterances that remain most untranslatable in emotion, language, gesture, ritual, genre. Understanding and working inside this paradox of translatability and untranslatability perhaps defines what we do in the humanities better than anything else. At Brown and beyond, there is substantial reason for us humanists not to whine about our underappreciation. Our medical school is keen on building its programs in medical humanities and ethics, telling us that these are dimensions that will ensure an experience of medical education inclusive of but not limited to medical training. Business education has turned to the humanities and to cultural studies, generically speaking, to offer grounding to theories and practices of global knowledge. These intersections, translations if you will, inform today's occasion. Christina Paxson's scholarly work fascinates us, among other reasons, for its clear consideration of issues across the disciplinary spectrum of the biomedical and social sciences as well as the humanities. Initially working on international economic problems of labor supply, mobility, savings, inequality, and aging, her work focused increasingly on the relationship of economic factors to health and welfare over the life course, particularly on the health and welfare of children. In 2000, she founded the Center for Health and Well-Being, an interdisciplinary research center in Princeton's Woodrow Wilson School. The center established multidisciplinary graduate and undergraduate certificate programs in health and health policy. Welcome, therefore, as president, scholar, and as center director. President Paxson's lecture today is entitled Health Inequality, Economics, Ethics, and Public Policy.
Thank you very much, and thank you for that wonderful introduction. I have to say, when I was invited to give this lecture, I thought, I'm a social scientist. Why am I being invited to give a lecture in the humanities? And there will be some numbers in this talk, but I think, joking aside, the topic that I want to talk about, which really summarizes a lot of work that I've done over a number of years on socioeconomic status and health and the relationship between the two and the implications for policy, is something that I think is of deep concern to humanists. And given the broad definition that Michael just gave, I think we're all humanists. And so I hope that people find interesting bits in this. What I will do is talk for about 45 minutes and then open it to questions. I want to show you some evidence, and I will, walk through it, but use a lot of words too. So I hope it's not too many numbers. I do care about facts, though. So, overview. So what I'm going to talk about is this really deep concern about health inequality that we see in society. And maybe it's better if I stand back here. Just to give some definitions to start, when people hear about health inequality, that can mean lots of different things. I mean something very specific here today. I mean, the fact that health status varies across people, the fact that it's unequally distributed, may be something that we don't like, but it's not something that would be really a cause for concern in terms of justice, right? I mean, there's randomness. Some people are healthier, some people are less healthy. And we try to ameliorate that, but it's sort of, we're biological beings and things fall apart at different rates for different people. When I talk about health inequality, I'm talking about something much more specific, which is inequality in health that's related to social disadvantage. And we'll talk more about different elements of social disadvantage. But I think it's this relationship, the fact that people who are more disadvantaged tend to have worse health outcomes, that's really been a cause of deep concern among economists, healthcare providers, and people who work in epidemiology as well as in medical ethics. So this is the topic for today. I'm going to start very broad and then I'll get down to some narrow topics. But just to give you an overview, I think most people here, and I'll show you some data to just give you the extent of this, but I think most people here realize that across a wide variety of health outcomes, health is strongly related to socioeconomic status, whether you define that by income, assets, education, race, and ethnicity. And these concerns have prompted a lot of discussion about health equity, right? And we want to come back later and talk a little bit about what health equity means. I mean, health equality is not the same as health equity in many instances. And it's also driven a lot of the policy debates that we see today. I mean, a lot of the discussion about the Affordable Care Act was really about the idea that there should be equity in the provision of health care. And I think if you pushed most people and said, well, why do you think that's true? The answer would be, well, healthcare affects health status, and we think that everybody should have the opportunity to be a healthy person if they can. Now, this is actually a really complicated topic. You think about income inequality. We have very straightforward mechanisms for redistributing income. They may not be straightforward to decide upon in Congress, but once you make a decision, you can have taxes and you can have transfer programs and you can change the distribution of income. Well, health status is something altogether different, right? It's not something that you can take away from one person and give to another. It reflects this very complex interaction between biology, between genetics, between environmental conditions, between individual choices of whether to smoke or drink or display different types of health behaviors. And finally, it also depends on medical care. One reason why I want to point this out, this long list, is that medical care is one of many things that influences health status. And so when we talk about health inequality, we talk about health equity, the conversation has to be about more than just healthcare. And that's a point that I really want to persuade you of during the course of this talk. Now, another issue that's been a big source of debate in both the economics literature and the epidemiological literature is what the mechanisms are that drive this association between health status and different measures of social status or disadvantage. And again, what I want to persuade you of is that this is kind of complicated. I mean, economic status can affect your health. Your health can affect your ability to work and earn and be productive, and so it'll affect your economic status. These relationships don't stay the same with age. Children are very different than adults, and prime age adults are different than people who are retired when it comes to the impacts of health on living standards. Did I just go out? Okay, I'm good. So we'll talk a little bit about those things too. And I went the wrong way. Okay. So just to give you an overview of what I want to cover, first I'm going to just give you some completely descriptive information on socioeconomic disparities in health. And this is just, some of you will know these facts very, very well, but others of you may not, and this will get us all up to the same kind of level of understanding on the basics. Then I will focus on childhood, and as Michael said, I've done a lot of research on childhood. This will probably be the bulk of the talk. But I will talk about how health in childhood is related to disadvantage and what that means for children's development and their success in adulthood. I'll turn to adulthood for a bit and really kind of get at this idea that your health can affect your economic status, which I think has very important policy implications. And also talk a little bit about healthcare quality and race, which is an issue that I think is particularly important in this country. And finally, we'll come up to some policy implications. So all that in 45 minutes. Okay, so descriptive information. And now I'm going to have to stand out here so I can point at slides, I think. So this is a slide. I'm going to start at the biggest. This is mortality. And the point here is simply that while we're very concerned about economic gradients in health status, health has improved a lot for everybody over the last 100 years, more than 100 years. So these are just deaths per 1,000 children, ages 1 through 4 down here, and infant mortality up here. You would get similar patterns if you looked at adults, but they would just be on different scales. For anybody who's interested, that's the 1919 influenza pandemic. But the point is we're a lot healthier than we used to be, which is a good thing. So what produced mortality declines? And I think this is kind of important because it kind of cites this whole range of factors that influence health. So if you actually look at, a lot of economic historians and others have looked at what's responsible for changes in health over this broad sweep of over 100 years, and they emphasize different factors at different points in the 20th century. So one factor, improved nutrition, increased caloric intake. What we saw was increases in heights of individuals over the course of the century as their nutrition improved. Another factor that gets talked about a lot are public health, improvements in public health, water, sanitation, pasteurized milk, vaccination campaigns. A lot of these really came in the early 20th century, going up into the 30s, 40s, and 50s, at which point, the kind of invention of new vaccinations, the effect on health in the US really came to an end. Medical interventions, in some sense, became more important over the course of the century, especially with the invention of antibiotics and then new treatments for heart disease. Neonatal intensive care is a big factor in mortality declines among very young children. There have been some declines in smoking and then reduced external deaths or reductions in accidents and homicides, suicides. So I think the important point here is that while we've seen these big improvements and declines in mortality and increases in life expectancy, we've also seen some increases in the disparities across different economic groups over that period. So just to show you a few charts, these are not from my own work, But these are from two different studies, and the reason why you need to compare these two and then these two, because they're from different data sources. But basically what they do is they show years of life remaining at age 25 in, among those with high school or less and those with any college, and then compare over time. So let's look at this data, the census data over here, which basically shows from 1990 to 2000 there was no change in life expectancy at age 25 among those with high school or less. The way you read this is basically 25, life expectancy at 25 would be 25 plus 49.7, so basically 75 years old. And what you see here is an increase in life expectancy among people who have at least some college education. So, some evidence of expanding health disparities. Now, I want to show you some information on morbidity. I mean, in some sense, people focus a lot on life expectancy and death, but a lot of medical care isn't focused on kind of just preventing death. It's focused on making people healthier, making them feel better while they're alive. Very important thing. And so these are calculations from a big data set in the US. And for the course of this talk, I'm going to be focused mainly, almost exclusively on the US and a little bit on England. But this is from something called the National Health Interview Study that's done every year in the US. It's a large sample, about 100,000 people, all self-report. There's some health measures which are self-rated health, which is excellent, very good, good, fair, or poor. It actually turns out that people who say that they're in fair and poor health are much more likely to die in the next 5 years than people who say that they're in excellent, very good, or good health. So while it seems like a very subjective kind of measure, it actually has a lot of punch when it comes to predicting what happens to people. We also know whether people say that they have a health condition that limits their activities, and then if so, what type of condition they have. And I'm going to focus here on income and education. In the question and answer session, we can talk a little bit about race and ethnicity. There's some interesting patterns here, but they're a little complicated. Okay. So just to give you a sense of what these patterns look like, and again, I'm not explaining these. This is just purely descriptive. So the first graph here on the left is whether people say their health is fair or poor. And this is by income group. So, and I just divided income into 3 groups. I could have divided it into any number of groups. You would have seen the same pattern. So, among those 65 and older, about 35% of people who have fairly low income report themselves in fair or poor health. Once you get up to 75 or more, it's only about 15%. And you see the same thing for whether an individual has a limiting condition. So again, big differences in morbidity. If you look at limiting conditions, and again, we'll just breeze through these really quickly. I put all of these on the same scale so that you can see among people over 65, arthritis is fairly common, mental health problems, at least reports of mental health problems are fairly low. But the common pattern across here is that this is cardiovascular disease. They're just big disparities across income groups. And then you can run through the same thing with education. High school, less than high school, some college, and a BA, or limitations by education group. Same thing. And this is, it's sort of true no matter where you look. A lot of people look at this and they say, oh, well, the US is different. We don't have universal health care. And so this is why there are these big differences in health outcomes across income groups and education groups, because low-income people don't have access to health care. And actually, if you take data from England or you take data from Canada, where there is universal health care, you see very similar patterns. So, they may be a little bit bigger in the US than in some other countries. It depends what measures you use. But, this pattern of economic gradients is really a worldwide phenomenon. Okay, just a couple comments here. These gradients appear when you have data that has biological measures of health status, so either doctor assessments or even things like, direct measures of hypertension or, all kinds of things. And they're also, again, not unique to the US. So there's some good literature that compares the US to England, and also one paper that I cited right there from a number of European countries. These are just example papers. There are lots of papers out there on this. The other thing that I think is really important, and we'll come back to this, is that these correlations don't say anything about causal relationships. We can't really say that health is caused by income or income is caused by health. We don't know. They're correlations. So when we think about what the different mechanisms could be that sort of relate social disadvantage to health, and I'm sort of lumping all of these income, education, everything together, but I think that the concepts work well regardless. So, one story is that social disadvantage, low income, low education, these things negatively impact health. So, and there are lots of good reasons why that might be true. So more disadvantaged people may experience more material deprivation, they may have worse nutrition, they may live in less healthy environments, have more adverse environmental exposures. They may receive lower quality or less medical care because they can't afford it, or maybe because they don't have the knowledge to use it effectively. There's actually a large literature on psychosocial stress and health outcomes. Some of that work has been done at Brown, some very good work that looks at psychosocial stress and health and how that relates to social disadvantage. And then worse health behaviors, greater smoking and drinking and things like that. So, but you can also tell stories going the other way, right? And that's the important thing, which is health can really affect your economic position. So, for example, less healthy people may receive less education. That would be less healthy children may receive less education. And I'll show you some evidence on that. People who are in poor health may earn lower wages, work fewer hours, and when they're old or when they get sick, they may spend down their assets, their wealth, in order to pay for medical care or expenses associated with poor health. So all of those things can be a route through which health makes you poorer, right? So that's something else there. These mechanisms are not mutually exclusive. They could go, both could be operating, and in fact what I'm going to argue later is that different ones are actually more important at different points in the life cycle. But I guess the important point here is, if we look at these health disparities and we're disturbed by them, as I think most people are, you look and you say, why should it be that someone with more education gets 6 or 7 more years of life to live, right? Well, you may think it's unjust that that's the way the world is. And the next step then is to say, well, what do you do about it? And you can't answer that question at all without understanding what the causes and consequences are of poor health. You need to know the mechanisms. Otherwise, your policy conclusions that you draw are going to be likely completely misguided, right? So for example, just to give you an example, if you thought that if it were true that it was just health creating social disadvantage, so the reason why people are poor is because they're sick and not the other way around, right? Then redistributing income, raising up the incomes of low-income people wouldn't do anything to influence the distribution of health. It would do lots of other good things, but maybe it wouldn't do that. So that's the kind of issue that we need to think about. Okay. So let me start with childhood. And this is something I've done a lot of work on, and I'm going to talk mainly about my own work. I listed a set of articles below. Almost all of them are with my colleague Ann Case and a number of other co-authors over the years. Just to show you that they're actually, there's some publications behind this. I'm not going to list them on each slide where I show some numbers. The overview here is pretty simple. What we argue is that health in childhood is related to economic disadvantage. Poor children are born in worse health, and that actually the health disparities become larger with age. They're more likely to develop adverse health conditions, and poor health in childhood has knock-on effects. It has adverse effects on cognitive development, on educational attainment, and on economic success in adulthood. So as you can tell, I think health in childhood is really important for a lot of things, because it sort of sets kids up for what happens over the course of the rest of their lives. Okay, so here's one graph that I will explain. And this is from one of our earlier papers on this topic. And this is family income. It's on a log scale. It doesn't really matter. And this is just the fraction of children who are rated to be in excellent or very good health by their parents. You get similar results if you look at doctor reports. And this is age 0 through 2. This is ages 3 to 5, 6 to 8, and down to 15 to 17. Well, you see a couple things here that are kind of interesting. One is that over time, at any income, health gets worse. Unfortunately, that continues throughout life. If you show this graph with people up to the age of 80, they just keep dropping. So childhood is, you start off at your very best there. The other thing, though, that is really interesting, I think, is that the decline in health status, the fraction as measured by this, percentage in excellent or very good health, is much smaller at the top of the income distribution than it is at the bottom of the income distribution. So in other words, these gaps in health status between wealthier and poorer kids become larger as kids get older. That pattern actually goes through adulthood, and then only starts to modify in very old age. Okay, so why do we see this income gradient in child health, right? There are lots of reasons why we might see it. You see the same thing with maternal education, by the way, too. But the way the literature on this has looked at the question is by identifying things that have adverse effects on child health, and then by making the case that lower income children are more likely to be exposed to those adverse things. So for example, infection, poor nutrition, prenatal exposure to smoking, those are all things that are more likely to occur empirically in lower income families or families with less education. There's some good work on environmental exposures that kind of does a good job showing that lower income kids are more likely to live in more polluted areas, and that's diesel fumes as well as toxic waste dumps. And there's also some really interesting work, and I have to highlight the work that's done by Brown researchers, on maternal stress and infant outcomes, and really makes a very good case that maternal stress is higher in lower income families, and that does not very good things to babies' health. And then finally, again, we have prenatal and medical care. And there's good evidence that prenatal care and medical care are important for children's health, but they're one of a large number of factors. Okay. One other thing we've looked at is, as children get older, what's the role of specific health conditions, right? So for example, is it the case that lower income children are more likely to develop asthma or diabetes or precursors of heart disease, which are becoming increasingly common in children? Or is it that the effects of those things are worse for poor kids than they are for rich kids? And so what we can do with the data, and I'll just show you some simple examples of this that aren't done in a very sophisticated way, is to really kind of decompose what we see, which is to say, okay, there's this what we call a prevalence effect, which is poor children are more likely to experience adverse chronic health conditions. And then a severity effect, which is if they have those health conditions, it does worse things to their health and their health outcomes. I'm going to skip this one. No, I won't. I'll just say what it is. I'm not going to go through it. When you actually look at specific childhood health conditions like asthma and bronchitis and hay fever and epilepsy and heart conditions and other things, and these aren't all the ones we looked at, you actually see very mixed message in terms of whether poorer children have more chronic conditions, right? For some conditions they do, for others they don't. For some it's kind of flat. I think asthma is kind of interesting because there is a marked gradient that sort of levels out by teenage years where wealthier and less wealthy kids are equally likely to have asthma. Again, according to parent reports, and there could be some bias there, I think that's important. It's also really hard to measure asthma among really young kids. Hay fever is positively related to income, and that may be due to environmental factors. But when you actually look at the data, what you find is that these, what I call severity effects, are really big. So what we see is that if a poorer child has a specific health problem relative to a wealthier child with the same problem, they have worse global health, they have more bed days, they have more hospital episodes, they miss more school. I'm not going to show you that evidence right now. And this is especially true for asthma and diabetes and epilepsy. Epilepsy isn't so common, but asthma and diabetes are fairly big deals among kids. So just to kind of give you a really simple example to demonstrate this. And this is, again, really simple. I've broken families up into income quartile from the poorest to the richest. And I look at kids who don't have asthma and kids who do have asthma. I say, what fraction are in excellent or very good health, right? Well, kids without asthma are always rated as being in better health on average than the ones with asthma. So, 68 versus 30, I can't read it from here, 38. 78 versus 52, 86 versus 65, right? So no matter what your income is, you're better off if you don't have asthma. That would be pretty surprising if that weren't the case. What you do see, though, is that among those in the lowest quartile, there's a bigger difference across these two groups than there is among the highest income quartile. Let me give you another example that I think maybe makes this a little bit more clear, okay? So this is looking at sick days, right? These are days home from school. I did show you this. And so again, these are kids with no asthma, these are kids with asthma. So, on average, kids miss about 3 to 4 days of school per year. Kids with asthma, if they're really poor, miss about 11 days of school per year. If they're rich, they miss about 7. So this gap gets smaller. Again, the same thing with hospital episodes, where an asthmatic kid in the lowest income is 11.8 percentage points, 11.8% of them have a hospital episode, as opposed to only 5.5% of those who are in the wealthiest group. So the point here is that when we look at the data, what we see is that, poorer children fare worse than wealthier children with the same health problems, right? And there are a number of reasons why that might be so. One is they could just have worse cases of whatever these health conditions are. Their asthma could be worse, right? Just inherently worse. Or, other health conditions could be worse. If there's emotional problems, they could be worse emotional problems. They could have lower health care quality to address those problems. Worse compliance with medical protocols. And there's actually some pretty good evidence on this, that kids who have asthma, who are from low SES households, socioeconomic status households, compliance with medical protocols is not as good, and there's poor management of healthcare conditions in terms of maintaining an environment that supports the health of children, and that goes into adverse environmental conditions. The point of all this, though, is that we have a situation where low-income children face this double burden, right? They're more likely to have not all health conditions, but most health conditions than their richer counterparts, asthma being possibly one exception. And they're also more likely to have worse outcomes given those health conditions, right? And so that's something that when we think about, health disparities, we really need to think about those two things separately, because simply trying to control, if you find out, there are no health disparities here in asthma, well, that doesn't mean that the effects are the same. And that's something that you need to think about. Okay, let me move to my next topic on children, which is what are the implications of poor childhood health for adult health outcomes? And there are a number of different pathways we've explored. So you can think about different ways that poor health in childhood can affect life chances going forward as an adult. One, which we've done a lot of work on, I've done a lot of work on with co-authors, is on cognitive development. And there's a lot of literature medical literature that suggests that many of the factors that promote better health also promote cognitive development. So, poor prenatal nutrition, exposure to tobacco smoke prenatally, a lot of these are prenatal issues, can sort of do both things, right? They can work through, and so if you have, slower cognitive development, if children are not reaching their full potential because of poor health, then you would expect that those effects to carry over into adulthood in terms of economic success. Educational attainment, less healthy children, as we see, might miss more school, especially given specific health conditions, may be less able to learn while they're in school. Health problems in childhood are going to carry over into health problems in adulthood, right? Most people aren't cured at the age of 18. And then we can also look at labor market outcomes, which can work both through lower educational attainment and through poor adult health. So, you can get these sort of effects where things kind of roll together so that lower income children have a tendency, again, this is just, we're talking about correlations, not, it's not true of everybody, but where the probability of having low education and poor health in adulthood would be higher than a child who grew up in a more advantaged environment. Okay. So I'm going to show you some evidence on this, and this is where I'm going to kind of skip over some things pretty quickly. This is actually a difficult, so if you really want to look at the kind of what early life experiences, what effects it has on long run outcomes in adulthood, it's actually really hard to do, right? And it's hard for the following reasons. One is you need data that follows people from the time they're children to the time they're adults, right? Either that or you have to be able to survey or look at adults and then kind of pull in information from when they were kids through administrative data or recall or something like that. But it's hard. The other thing that is difficult is to really nail, and this is something economists obsess about, I'm looking at Andrew sitting in the back of the room, is really to kind of nail causality, right? You can get these associations. It could be that poor health in childhood is associated with poor outcomes in adulthood. Does that mean one really caused the other, right? Well, you can do a good job using these, what I call observational data, to kind of make a good case. To nail things, you really have to do things like, kind of subject people to experiments where you sort of, give one child randomly more income and better health and see what happens over 40 years, but most researchers don't want to wait for 40 years to get results. So, this is just sort of a caveat, which is what I'm going to show you are these associations. I think we've done the best job we can, but one can always worry about these issues, and I think they're serious issues. Okay, so what am I going to show you? What I really want to show you is that, so let me come back to one thing, which is data issues, health measurement. One of the problems that we have is a lot of times we look at data at adults and we know nothing about childhood, right? We don't know whether they were healthy in childhood. And we do know one thing about them, and that is how tall they are. Now, it turns out that height is correlated with health in childhood, nutritional status, things like that. And so you can use height not as a perfect measure, but as a very noisy marker of someone's early life circumstances. Height in adulthood is very highly correlated with height at age 5, right? And a lot of growth happens between the ages of 0 and 5. So height kind of gives you a bridge where you can sort of see, you observe it in childhood, you can observe it in later years, and it serves as sort of this marker for what may have happened earlier. So what I want to do here is kind of give you some evidence that suggests that health in childhood really is associated with cognitive development, with educational attainment, and then with labor force outcomes later in adulthood. This graph is from something called the National Longitudinal Study of Youth. It's a US data set. And this is looking at height at age 5 and then these cognitive test scores at age 5. I think the ones that are the most interesting are right here. And this looks within groups of kids who have the same mothers, siblings. So essentially the experiment is you have two kids, they're siblings, one is taller at age 5 than the other one was. At age 5, which one is doing better on the cognitive tests? And it's the taller one, right? So by looking within a family, you sweep out the fact that, you know, they have different, sure, they're going to have slightly different environments, but a lot of those environmental factors are going to be controlled for just by having these kids be in the same family. So also from the MLSY, we can also look at other things within sibling groups. And one is that shorter children are more likely to fall behind in school than their siblings who are taller. And also within sibling groups, taller kids are more likely to have had higher birth weights and lengths and to have fewer limiting conditions. So you can look at the data and really tell a story that, you know, these sort of, you know, height, health, cognitive development, educational attainment are really moving together very early in childhood. This is something that looks at low birth weight, and this simply compares children who are low birth weight relative to their non-low birth weight siblings. So we've cut height out of the picture. We're just going straight to low birth weight. And what you see here is that by age 8, the taller and shorter childhood are no less likely to have fallen behind in school. Well, they only had 2 years of school. It's hard to fall behind by age 8. By age 14, actually, though, the low birth weight child is about 8 percentage points more likely to have fallen behind. Falling behind in school in the US is one of the biggest determinants of dropping out of school because you can leave school before you've graduated. So, you know, you can see bits of evidence that health in early childhood actually is mattering for educational attainment, which is something that has a huge effect on well-being in adulthood. Okay, for the longer run analyses, and I won't spend that much time on the data, we have to move out of the US. And the reason is the US, although we're in the process, knock on wood, of developing a good birth cohort study, and this is also something that Brown is taking part in, we don't, like England, have these long-run birth cohort studies where they've been tracking people for years and years and years. So for example, there's a 1958 National Child Development Study that surveyed all children born in a single week in 1958, and it's been tracking them ever since, right? It's easy for me to remember their ages because they're just 2 years older than me. So there are more waves of data available than we used in this study. And there's some other birth cohort studies there. So I'm just going to give you a summary of the results, and I'm going to just skip over the tables quickly. So what we see is that poor health in childhood is measured by prenatal smoking, birth weight, height, chronic childhood conditions, these are assessed by doctors, is associated with lower labor force attachment in childhood, in adulthood, so people who are less likely to be employed, lower occupational status. In British surveys, they have this great way of grading occupations by status, something you don't see in American data. Lower earnings, poorer health, and even worse cognitive function in older age. So again, I'm going to go through this. I'm not going to do this. But I can tell you what, there are numbers here. We did a lot of work. I'll tell you what we did. Okay, that shows that we did a lot of work. So what do our results imply? This is the kind of thing that you get out of the results. That a boy exposed to prenatal smoking who's born at low birth weight, which is associated with prenatal smoking, and who has one chronic condition during childhood is predicted to have reduced educational attainment relative to a child who has none of those factors by an amount that corresponds to 8.6% lower earnings as an adult, 30% lower earnings at age 33. So basically what that tells you is reduced education, which knocks down earnings. Even controlling for education, earnings is lower still. And the probability of being employed at age 33, I just picked 33, is 13.6 percentage points less, so much higher unemployment. So the point here, and we get similar results from other data in the US using mainly administrative data. There's a good paper with sibling pairs that looks at the long-run impact of low birth weight, which is associated with big reductions in earnings and probability of dropping out of school. And then I think a paper that is really quite persuasive, although it's on a different country, is this paper by Black, Devereaux, and Salvanes that looks at Norwegian twins. They have great administrative data for years, and within twin pairs, low birth weight is associated with reduced height, IQ at age 18, earnings, and education. So I think the point here is if you put all of this evidence together, and you look not just at the studies I've done, but lots of other studies, you can tell a really good story that what happens early on has very important effects as you go forward. So health in childhood matters a lot for a lot of economic outcomes. Okay, let me turn to adulthood, and I'm going to try to move a little bit faster. So adulthood, I've actually done less work on adulthood myself, so I'm going to be talking mainly about other people's work. So when you look at adults, now this whole thing about whether income drives health or health drives income or economic status becomes much harder to disentangle, right? Because once people are in adulthood, both things could be going on at the same time, and trying to figure out which is hard. So I'm going to just talk about a couple of pieces of evidence that I find particularly persuasive, right? One is, I think there's some quite good evidence that adverse health events in adulthood can do really bad things to your economic status. So this is from a study, Jim Smith, who's at Rand, who used data from something called the Panel Study of Income Dynamics. It tracks people over time, collects some health data. And so what you can do is you can look at, you can do the following type of thing, which is to say, so suppose someone has a major health episode. They develop heart disease, they have a stroke, they have cancer, or there's one other thing in there, I'm trying to read it, lung disease, serious lung disease. Well, what happens going forward? What happens to their income, their earnings, their probability of working? And what you see are, pretty bad things. Decline in the probability of work over a 10-year period of about 27 percentage points. Medical care costs out of pocket of about $4,000, so that's over and above health insurance. And then income loss of about $37,000. For more minor health problems, you see smaller effects. And the other thing that I think is really important here is that when you do the reverse experiment, and you sort of say, well, do declines in income predict health events, adverse health events going forward? The answer in these data is pretty much no, right? You really don't see any evidence that economic fluctuations drive future health problems. So this evidence is really consistent with the story that in adulthood, the major route kind of pathway is from health to economic status. The thing I think that's very important here is in this study and in many other studies, what you see is that education just really matters. I mean, people who are more highly educated are in better health, they're less likely to experience any of these events. So income fluctuations don't really predict health problems, but education does. And that's a very robust result. Okay. There is some evidence that goes the other way. So I don't want to say this is the only study out there and this is the only finding out there. For example, there's a really good recent study, Sullivan and von Wachter, who looked at really large economic shocks that occurred in Pennsylvania when basically they were working mainly in western Pennsylvania when the steel mills shut down. And I like this work because I grew up in Pittsburgh around the time when the steel mills were shutting down. And what they show is that these job displacement that occurred as a result of this really terrible economic event is associated with a very substantial increase in mortality. I always found that very compelling, or not always since I read the paper, because at the time, a lot of the recession was associated with a lot of increase in alcohol use and mental health problems and things like that. So I think the point here is that these were really large shocks. So maybe in the work that Smith is doing, when he's looking at economic fluctuations and what happens 10 years out, they're just not of the same order of magnitude, and that's a possibility. Okay, I'm going to talk a little bit about race, and then I will conclude, but I think this is important. So in the US, I haven't shown you any statistics on race, but if you look across blacks and whites, especially in the US, you see big health disparities in almost every measure. Hispanics are a little bit complicated because there's sort of differences by immigrant status, and this group is not a homogeneous group. So I'm going to put that aside, but I'm just going to focus really on black-white differences in health. So I think that one thing that's important is that racial differences in adult health, and this is true for children as well, in part they reflect the fact that race in America is associated with education and income, right? People who are, average education levels are lower among African Americans than they are among whites, and education is associated with health. But I think the thing that's important is even when you sort of say, well, let's look at blacks and whites with the same level of education, you still see health disparities. You still see worse health among blacks than on whites on average. And that's true if you look within income groups as well. So what's going on there? And I think the evidence here is really quite a very interesting story. Medical care appears to be a big part of the story, right? And what I've been talking about earlier, I didn't really stress medical care. I mean, that was part of it, but we're also talking about nutrition and infection and environmental exposures. And there may be some of that here too, but there's some pretty good evidence that African Americans are less likely than whites with similar disease profiles of receiving the same treatments, right? Well, what do we make of that? Well, it's interesting. There's there's sort of two hypotheses, and one is just discrimination. And I think the most compelling way to get at discrimination is through these vignette studies, where physicians are given cases where everything's identical, but things like race and gender and sometimes age are varied. They don't know, presumably, that they're being tested for racial discrimination. And they're given the opportunity to talk about what treatments, the protocols that they would recommend. One thing that kind of bothers me about this literature is that the vignette studies that show evidence of bias get a lot of press. But when you actually look at the literature overall, you see as many studies that find no effects as find effects. It's a very mixed bag. So I think that's not to say that there's nothing there, but I think there's a lot more work to do in that area to figure out why in some vignette studies you find no evidence of bias and others that you do. Maybe the studies are just conducted differently, the way questions are framed, the way the experiment is put together. All of these things can be really important for results. So I think that's an area that just needs more research. The area that I think is really interesting really looks at geography in a way. And there's some really good evidence that it's not that within healthcare settings, blacks and whites are treated differently, but that blacks tend to be in worse healthcare settings, often driven by geography. So let me just show you what I mean by this. And I think this is very important for policy issues. This is from a paper by John Skinner and a bunch of co-authors that was published in 2005. And what it does is it shows 90-day mortality after an acute myocardial infarction wait, which one do I want? I want this one. For whites and African Americans, so African Americans and whites. And these are sorted by hospitals, from hospitals that serve the lowest numbers of black patients to hospitals that serve the highest numbers as a fraction of overall patients. So what you see here is something that's kind of interesting, and you also see it on this previous slide too, although this is where you do adjustments for age, race, and sex. But the basic story here is that outcomes are really good in these hospitals down here that virtually only serve whites, right? When you get to the hospitals up on the right-hand side, right, these are hospitals that serve large fractions of African Americans. Mortality is higher, but it's higher for both whites and blacks. These are just bad hospitals, right? So it's an interesting story because it's a story of, I think, injustice in terms of racial disparities in health outcomes. But the story is, again, not the obvious one of differential treatment within a healthcare setting. There may be some of that because you still see little gaps even within. But the main difference is across these hospitals. Okay, let me wrap up with some policy conclusions. So I know that this was sort of a whirlwind tour, but I did want to come back to health equity and public policy. I like Amartya Sen's work on this topic. I think he's a great philosopher and a great economist, and he's thought hard about health issues. And he has a quote in a paper published not too long ago that he says, health equity cannot be concerned only with health seen in isolation. Rather, it must come to grips with the larger issues of fairness and justice and social arrangements, including economic allocations, paying appropriate attention to the role of health in human life and freedom. And then he goes on to say something that I think a lot of people might find quite controversial, which is health equity is not just about the distribution of health, not to mention the even narrower focus on the distribution of health care. Indeed, it has enormously wide-reaching relevance. And what he's saying here, I think, is this, so kind of the evidence that I've been going through today, and the reason why I really wanted to take you through the evidence and let you see the data, is that, health is sort of one factor in this kind of complicated story of social inequality more generally, right? It's something that can be a product of social disadvantage, economic disadvantage. It's something that could be a cause of economic disadvantage. It doesn't mean if it's one or the other that it's any less disturbing, but it means that we may think about it very differently in different settings, depending on what the exact source is. So I think my main bottom line here is the source of these disparities matter when you take your concerns about equity and then you actually want to translate them into specific ideas about policy. So with that, people say, okay, what are the right policies? I don't know. I mean, public policy is hard, and there's a lot more work that needs to be done to say this is what we must do to eradicate health disparities. But I think we get some hints from the work that we have seen. So if we want to reduce health disparities that result from social disadvantage, presumably we want to do this by bringing up the health of people at the bottom rather than reducing health of people at the top. That's an easy way to do it, but we're not going to go there. And I think looking over the literature overall, and not just my own research, that there is a really strong case to be made to pay a lot of attention to the health of children, health and development in early childhood. That seems to be something that has a high payoff. These are things that last forever, or a very long time. The question for us really as researchers, and a lot of people in this room may be medical researchers, is what programs and policies are most effective? It's not all about medical care. So for example, there's some really good work on the long run effects of early home visiting for at-risk children, right? That's really important. And that might be an intervention that really doesn't have anything to do, well, nurse home visiting, so yeah, there's medical in there, but it's not medical care in the traditional sense. It's really helping parents be better parents and learn how to take appropriate care of children. So there are lots of different policies and programs in there. I think the general point here that I want to make is this is a really good place to focus. The other point that I would make is that post-Affordable Care Act, the focus should really be on healthcare quality. And maybe it should have been on healthcare quality a lot more before the Affordable Care Act, right? When you look at the evidence that I showed you on chronic childhood conditions and the fact that lower income kids do worse with the same conditions than better income kids, healthcare quality in terms of health, both in terms of healthcare delivery, but also in terms of helping parents manage health conditions, that's important. And when you look at the work that I just showed you on racial disparities in health outcomes, I think there's really an important healthcare quality story here that we need to pay attention to. Okay, the other thing that I would put in here that I think most people don't really think of when they think about health disparities are ways to reduce the adverse impact of health outcomes on living standards. So, in childhood, we've seen that kids who are in poor health have worse educational attainment. Maybe you can't make them healthier, but maybe you can attenuate that through appropriate programs or policies. The other thing we saw was that in adulthood, people who have serious health incidents experience really large reductions in their income and their assets and their ability to work. And especially in an era where retirement ages are going up, right, with Social Security, we're losing our safety net for people who experience really bad health outcomes between the ages of 50 and 65 or 67 or 70. There's obviously a moral hazard issue here, and I think a lot of people know that countries with more generous disability insurance programs, which are there to buffer people who become ill, there are problems with people who aren't ill getting onto the programs, and they tend to be very expensive. But on the other hand, if you think about health equity, do we think that it's just that someone who develops a condition has to pay a serious consequence, that there's really no mechanism for them to be insured against something like that? We can argue that, but I think we could do more in that area. Finally, last thing I'm going to say, when you look at all of this literature, education is so important, right? It's something that is affected by health in childhood. It's something that is associated with health behaviors and health outcomes throughout life. I didn't show you evidence on education and things like smoking and all sorts of bad health behaviors. But paying attention to education as, education policy as health policy is something that I think is pretty important. And that may be, trying to make sure that kids graduate from high school could be one of the most important things we do for them in terms of their health. That's sort of a speculation. We don't have firm data on it, but I think there's a lot of evidence pointing in that direction. Okay, I will stop. I think I went over 45 minutes. But. I will take a couple questions if people have the time and patience. How long do we go, Michael? For another 10 minutes?
Go
or
10 or 20 minutes and then.
Okay.
You can go 10 or 20 minutes and then you're welcome to join us for a reception afterwards.
Yes, sir.
Yes, well, I'm a Brown graduate from the 1950s, and that was a period where black athletes were coming into schools and competing in sports, and one would assume, as I was healthy at that time, I would have assumed that they were fairly healthy too, because they were better athletes than I was. But I continue to compete at Masters competitions, and I wanted to suggest to you that the Masters runners might be a research subject. And I am now in the 75 to 79 age group, and there are less runners altogether in that age group than there were when I was in my 60s. But there are almost no lads who run, say, after 65 or 70. And I'm not certain why that is, whether it's an income problem or a health problem. But I wanted to point out, too, that when I went to college, there were 20% of the nation's high school graduates going on in college was an ally together from the 60s. And so on the basis of what you said, that we ought to have a somewhat healthier population.
And we do. And we do.
And we do last longer. We certainly, you know, we sit in the 50s while men were retired at 65 and dying at about 70.
That's right.
It's quite different today.
That's right. And that's why I wanted to start off with that graph that showed mortality declines, because it is important to put everything in context of health getting better over time.
I don't think people have, in fact, I know research the masters runners per se.
I have never. Thank you. Thank you. Yes.
Thank you. That was a very thought-provoking presentation. You know, when you look at the Affordable Care Act, one of the things that it does do is increase the coverage of uninsured Americans. So it should decrease the number of uninsured Americans from about 50 million to maybe 23 million. And a large number of those people will be relatively poor Americans. So what do you predict is the relationship between parents, poor parents who have insurance and presumably would get more health care, and the effect of that on their children?
So you know, most low-income children, not all, but many have been covered by Medicaid for a while. So the biggest effects are on low-income adults who have not had coverage, adults who are not parents. Now, one thing I would hope, but I don't know whether I can expect this, is that especially young women who are now insured when they weren't before can get better preventive health care that can make them healthier when they go into pregnancies. You know, right now, women don't get onto Medicaid until they become pregnant, and that's kind of late. You know, you sort of want to do smoking cessation before you get pregnant. So, you know, doing things to improve women's health, I think, is really important. I guess I'm, you know, a little bit concerned that, and this is where I come back to quality, which is the kind of health services that a lot of the groups who are going to be newly insured need are things like preventive care. They're you know, smoking cessation. They're you know, help with drug abuse. They're mental health issues. They're not sort of the I need to go to the doctor to have a specific procedure done, because most of those things were being done anyway through emergency care, right? So my concern is that the coverage may be there, whether the quality is there to really support the health of people in this group. I don't know. You can tell me.
Well, I mean, the Health Care Act does provide a lot of more preventative care.
Yeah.
And you're right, maybe some of the preventive care that it covers doesn't address some of the issues that you're specifically talking about, but certainly,
Right.
you know, the emphasis on prevention is a major part of,
Right.
of the Affordable Care Act.
Yeah.
So I do think people are thinking about kind of those long-term issues.
Right. But I do worry also in the short run with more people, especially since a lot of people are going to be newly enrolled in Medicaid, that without adequate resources, it could have a diluting effect on the quality of Medicaid for all people who are in the program. And that's a concern. Yeah. Questions right over here.
Thank you for a sweeping and insightful talk. And you covered about half of my field of medical sociology in less than an hour, so that's impressive. I appreciate it. And I'd like your slides.
Okay, good.
So when you were talking about international research, I of course thought of Richard Wilkinson's work and that of his colleagues in the UK, where they show that above a certain level of GDP, the basic predictor of mortality differences and a variety of morbidity differences between countries is the Gini coefficient. So that's the difference. The gap between the wealthiest and the poorest in the country is the best predictor of that country's mortality and morbidity relative to other countries. And he suggests that this is related to social cohesion, or a lack of social cohesion, to a lack of trust, to a lack of ability to find common ground. And that resonated with some of your findings, even though it's a long way to nail down that analysis and causation. So I wondered your reaction to those suggestions and what you can suggest for those of us who are educators to increase the public awareness of this broad contextual way of viewing health inequality and health equity.
You know, I've had debates with Richard Wilkinson about his work, and I actually don't think the conclusion is right. I just don't. So the argument that he makes, so there's two different things. See if I can explain this, right? One is that income is related to health, and it's sort of, as your income goes up, so what happens is if you spread out the distribution of income, if sort of health gets better but at a decreasing rate, it lowers the average, right? That's sort of one version of the argument, which is not this social cohesion argument. The other is that inequality is something that sort of is out there. It's sort of like environmental pollution. It's bad for all of us, right? So if you live in a more unequal society, it's bad for the health of wealthier people as well as the health for lower income people. It's very difficult to tease those apart empirically. One of the papers that I had on the slide but I didn't talk about, which was a paper by Deaton and Labotsky, really takes apart that hypothesis using data on inequality in American cities, where you see this sort of association with the Gini coefficient and worse health outcomes. He actually shows that, at least in the US data, they show that once you control for the racial composition of cities, comes up to this racial, it's really about racial disparities. It's not really about, cities where there's a lot of inequality are also cities where there are high racial disparities. So it's a different story. So I don't think that exact mechanism is settled. I do find, so there's also, though, a large body of related work that really looks at psychosocial stress and health. And there's some pretty good evidence from that, both from animal studies as well as human studies. And, you know, that's sort of the Marmot kind of Whitehall study work. And I find that a little bit more compelling based on that research as well. But we could argue about the Wilkinson stuff. You may like it, I don't know. But
well, I think it does suggest possibilities for interventions at a more macro level and at a more policy-driven level. And at the very least, it suggests that we do have a stake in one another's health, and we do have a stake in the health of our given area. Your data on hospitals in particular suggested that.
You know what, this is actually a really good point, and it's something I should have said before. There's sort of, you know, one theory is inequality is just like pollution. It falls on our heads and it makes us all worse off. The other, though, which I think is an important issue, is that more unequal societies may be less willing to invest in public goods, right? And so they may be less willing to invest in really good healthcare systems, and so there's a mechanism that roots through the quality of services that are provided. I don't think, you know, Wilkinson's work doesn't make that distinction. He's looking very macro. I think it'd be important to know the answer to that. Yeah. Other questions? I think you had your hand up for a while.
I think your one joke was we don't want to make it worse, right? Unfortunately, that's what we've been doing over the last 30 years, right? Social inequality has been getting worse. Racial disparities have been getting worse. So while it was funny for a second, it's actually the policies that we've been following. And just with respect to some of the data that you showed, you made some assertions. One assertion was that neonatal intensive care units improved care. If you look at the chart, and you looked at 1 to 3 month care, which is where the greatest magnitude is going to be, there wasn't a dramatic change. It would be my argument, if you closed them all and did what they do in Cuba, which is have people visit girls, biggest risk factor, 13, 14, 15-year-old girls, in their homes, make sure they get prenatal care, make sure they get other social services, you will not only reduce that 1 to 3 mortality, it'll be cheaper than the intensive care, and you will not reduce the production from those neonatal care centers, which are basically people who are going to be chronically dependent forever. You have, and just one more gap on the same graph. Medical interventions did not have any impact for most of the top of that graph either. Streptomycin didn't come in until the late 40s.
Absolutely.
Penicillin was the only antibiotic until the 60s. There's been a lot written about that needs to be accounted for in all of this discussion. Medical care needs to be distinguished from health. Health is a function of other things, and it's too often conflated.
I guess, I mean, on the decline of mortality, I was trying to say that different factors played a different role and medical care became more important at the end. Neonatal intensive care units, I think there are very valid debates about whether they're worth the money. They're very expensive. And whether they're, saving kids who are going to have serious problems, whether there aren't better ways to spend money. But if you look at the diffusion of neonatal intensive care units, especially across the US and Britain, you do see that infant mortality declines when neonatal intensive care units come in. So I think there's pretty good evidence that it had an effect on infant mortality. I think what you're saying, though, which I agree with, is that there may be other interventions out there, maybe for older children, maybe not, that are much more cost effective than these types of treatments. So
they're real prevention. Real prevention is not smoking intervention. Real prevention is putting the presidents of tobacco companies and their boards of directors in jail. Real prevention is stopping marketing of McDonald's and cereals on TV. That's real prevention. Because you said people make these choices. These people who are making these choices are infants. 1, 2, 3, 4-year-olds. They're making choices. It's a cartoon in the New Yorker. It's a fishbowl. The big fish says to the little fish, you can be anything you want to be, as long as you're in the fishbowl. Okay? There are no choices. Okay? And I practiced in Mississippi. Unbeknownst to me, I integrated the first private practice in Mississippi. I had no idea. Okay? There are all kinds of other disparities that are very real that relate to health care. This is Durkheimian construct, right? You can only understand one social class above us, one social class below. He didn't talk about race, but it's certainly similar with respect to race. And the myriad ways a white person interacting with a black person screws up, okay, when it's in a power relationship, relates to those disparities and those outcomes. And I hope at Brown we can try to turn that around by again, perhaps, being more representative of the population of the country in the medical school. Maybe something you might think about as president, as a targeted project. That would be a serious intervention into this kind of a solution to this kind of disparity.
a lot of interesting ideas. Let me take another question. Yeah, over here.
Could you discuss the degree of correlation between specifically educating girls and the age of first pregnancy, and how that may in fact transcend many other factors in raising all votes?
You know, it's interesting because, I've also, the work that I didn't talk about today was I've done a lot of work on child maltreatment. And, that's a serious health problem for young kids and very highly correlated with age of mothers. So really young mothers are more likely to abuse their kids. So I've always said, one of the real benefits of education for kids is simply that they have older parents, right? You're delaying births until later. And that does other things than just prevent child maltreatment. It also leads to healthier babies along lots of other dimensions. So, so when I said at the end, education policy is health policy, you can bring off, you can talk about smoking, you can talk about child maltreatment, you can talk about birth weight, you can talk about so many different pieces of health where education is a piece of that story. So I think I'm agreeing with you, but I think it's very important, yeah. Yes?
I have a quick informational question, and then I want to ask you to speculate about something. The black twin study,
Yeah.
They were fraternal twins, were they not? Otherwise, that was.
They were a mixture of fraternal and,
Oh, okay.
yeah.
I wondered if you'd speculate about line, there seems to be more consensus of the importance of equality in healthcare than in education. It seems like it's an easier sell to the public, and I wonder if you had any ideas about that.
You know, it's something I've thought about a lot, and I think it's a really good question. You know, so the argument that you always hear about healthcare, and you know, you get this when you read Sen's work or the work of other philosophers, is that you know, health is just an essential part of human capacity, and it lets us work, and it lets us enjoy freedoms, and it lets us do all of these other things, right? You can make the same argument about education, too, right? So the question is, why is health different? And I think it is. Part of it, I think, is, you know, we think of education as something that we are a contributor to having happen. You know, you work hard, you study hard, you get a good education. So it's sort of thinking about education as almost an outcome of your own behavior. When people, and actually when you look at health, where health is affected by behaviors, many people, I wouldn't be one of them, would argue that, well, you know, if you caused your own health problems, we shouldn't worry about it as a society because you exhibited worse health behaviors or better health behaviors. I don't think that's right, because I think the health behaviors come from somewhere. But I think, you know, to the extent that health is something that happens to you, whereas education doesn't happen to you, it's seen in a slightly different light. I don't know whether you find that compelling, but it's curious that it really does strike a very different chord in people than almost anything else.
It does strike a different chord.
Yeah.
And education happens, too.
It does.
It does. Education
Yeah.
happens to people.
Yeah. I mean, the way I think about it is, personally, I mean, so economists often think about human capital, right? And I think health is a component of human capital, just like education is a component of human capital. And a lot of the work I've showed you sort of thinks about health and cognitive development as really being very closely intertwined and really sort of the same thing in some sense. I mean, so yeah. So this sort of health exceptionalism and ignoring other really important inequalities doesn't always make much sense to me.
But you did give a good suggestion, which I had never thought of. That people perceive it as something external.
Yes, I think that's right. There was a question right up. One more? Didn't you have a question? Yeah.
I just want, because that came up right now, I think there's like increasingly a lot of more evidence about how sort of early childhood health and really that early period translates into real educational differences and attainment. So in a sense, you know, health policy is actually education policy as well.
That's right.
Because like
Early in life, yes.
and maybe if this is a suggestion, and maybe going back to what you're saying, if you kind of put out that suggestion more and draw out that association more, people will come and start to see that, you know, education and health as a much more concrete thing. I don't know how that can be communicated to, you know, generally public more and more, but it sounds like
Yeah,
that's where
and I think a lot of people would get the idea that your educational status can affect your health behaviors and the level of stress and, you know, a lot of things that affect your health going forward. I think it's probably less well appreciated how early life health can affect your ability to learn and advance in educational systems. And I think it's important. So, good. I think that's it.
Please join us in the back.
Thank you.